بحضراتكم في مراجعة الموديول بتاع الفيميل ايميجينج، واحنا الحمد لله وشكنا على نهاية الدبلومة بفضل الله سبحانه وتعالى، وباقي بس موديول واحد بعد كده، وإن شاء الله الأمور كلها تبقى ميسرة بإذن الله تعالى. هنبتدي بالحالة الأولانية. This is an MRI of the pelvis, and this is T1 fat set, and this is the T2, and this is also T1 fat set with contrast. Red degeneration. The right answer is dermoid, ovarian dermoid cyst, because of the fat. This is the suppressed fat within the lesion, which contains as well some of the fluid signal. And this is the appearance of the fat in the T2 weighted image, which is almost similar to the subcutaneous fat. And also here the fat is almost similar to the subcutaneous fat, and this is ovarian dermoid cyst. Next case is a female patient, 25 years old, with right-sided pelvic pain, worst 4 days into her menses. Yes, and this is endometrioma. You see that there is a shading effect of the lesion in the ovary compared to the bright signal in the urinary bladder, as well as the bright signal in the endometrium. And this is what we call the shading effect, which is one of the characteristic findings of endometrium. Next case is a female patient, 31-year-old, with a nodule at the cesarean scar site, localized pain during menses. Yes, and this is what we call a scar endometrioma or endometriosis. The implantation of the endometrium at the site of the scar will form some mass in the subcutaneous tissue, and this mass became painful during menses. Next case is hysterosalpingogram and MRI of the same case. No, and this is not uterus diadelphys, because in cases of uterus diadelphys, the both cornea should be separated from each other. They are not attached by myometrium, and actually this is a septated uterus, and this is the right answer. You know that this is the inseptated uterus. The uterus is almost similar to the normal uterus, but it has an intra-cavitary septum, and this septum may be partial or may be complete. In cases of uterus diadelphys, you got both uterine cornea are almost totally separated from each other, like this one. This is the classic appearance of uterus diadelphys, and in the previous case, we or the radiologist who performed the examination introduced the cannula in the cervix, and he could not notice that there is another cervical opening. So you may diagnose this as unicornuate unicornis uterus, but actually these malformations are better evaluated by MRI. And here, if you can identify the two cervical openings in you, this happens for me, one once, and I could see two cervical openings, and they put a catheter here and there. Then I opacified both uterine cornea, and you got the diagnosis of uterus didelphys. Next case is a female patient, 31 years old, with chronic pelvic pain and dysmenorrhea. Yes, and this is the right answer, pelvic congestion syndrome, where you got multiple dilated venous channels in the pelvis surrounding the uterus. And also, if you have sections high up, and you can see that the ovarian vein is also dilated. And this is a diagnostic feature of pelvic congestion syndrome. Next case is a female patient, 72 years old. She had recent surgery for urine incontinence, and the patient presented by fever and foul-smelling vaginal discharge. Actually, this is not a tube ovarian abscess, this is the uterus itself. Yes, the right answer is biometria, and this is actually infected the uterine cavity. It looks like if the uterus itself became as an abscess. It contains pus and also some air fluid level with thick enhancing margin and some stranding of the surrounding fat. And this can, if you can identify some fluids inside the uterine cavity, the etiology is like this. In cases of pus, it is known as biometria. If it is a sterile fluid, then you call it hydrometria. If it is blood, then you call hematometria. And the fluid can be seen normally in menstruating and pregnant women, and larger collections may occur when the uterus is obstructed, like by cervical cancer or uterine leiomyoma or some sequelae of radiation or even post-surgical scarring. If the collection is infected and you got high CT density and also abnormal increased signal intensity. Next case is a female patient, 36 years old, with pelvic pain, dyspareunia, and dysmenorrhea. And this is not endometrial carcinoma, it is not also a dermoid cyst because this is the uterus itself. And here you can identify the ovaries. And in the uterus, you got multiple enhancing masses, and they are simply representing fibroids by CT. And I know that you are not used to see fibroid by CT. All what you can see in the CT images is just a diffuse enlargement of the uterus, maybe with bossy outline and some matrix calcification. But sometimes if you inject contrast material and you got significant enhancement of the uterine fibroid compared to the enhancement of the myometrium. And next case is an MRI of the pelvis, coronal T2, coronal T1, coronal T2, and sagittal T2. I think that this is T1 with contrast. And no, this is not endometrioma because there is no shading effect in the T2 weighted images compared to the fluid in the urinary bladder. Hemorrhagic ovarian cyst should have some increased signal in the T1 weighted images. you may say that this is a simple ovarian cyst, and yes, you may say that this is a simple cyst, but if it is somewhat large and you may see some internal septations here, you cannot see, but this lesion was proved after surgery to be a mucinous cystadenoma. Actually, the right diagnosis is simple ovarian cyst because you do not have some of the features uh, of the cystadenoma. Next case, and this is axial T2, coronal T1, and sagittal T2. Yes, right answer. Then this is ovarian cancer. You got a very big mass in the region of the cervix, and it's clearly identified in the sagittal images as well as in the coronal image. It is infiltrating the upper part of the vagina and causes some mass effect on the urinary bladder, and this is cervical cancer. Next case is a female patient, 18 years old, with a big mass in the pelvis. And yes, this melanoma. This appearance, in my opinion, is considered a spot to diagnose. If you have a big mass in the pelvis in a relatively young age, and you think of an ovarian endometrium, an ovarian dysgerminoma, particularly if you have enough sections to see that the uterus is not involved, then this is the ovarian dysgerminoma. And you know you have two types of dysgerminoma, in the ovarian type, the juvenile type and the adult type. And this may present by precocious pseudopuberty, and it may have some association with Ollier and Maffucci syndromes. The characteristic appearance is a very big mass in the pelvis. It may be totally solid, may have some cystic changes, or may have a predominantly cystic appearance with some solid component, especially in this particular age group, and you can diagnose ovarian dysgerminoma. Female patient, 20 years old, with acute left lower abdominal pain for the last 4 days. Yes, very good. This is ovarian torsion, and you see that the left ovary is markedly swollen, and it has an increased signal intensity in the T1 weighted image, denoting some congestion or even hemorrhage. And this is the appearance of the torsed ovary in the coronal T2 weighted image. This is the normal right ovary contain multiple variable sized follicles. Then the ovarian torsion usually affects the children, young and postmenopausal women. Maybe there is a predisposing factor, which is usually a dermoid cyst or an ovarian cyst. It should be benign because the malignant lesions may prevent the ovary from being torsed. Then sometimes you got ovarian torsion in about 20% of the patients during pregnancy, and the torsed ovary is usually on the right side because it is suggested that the sigmoid colon may prevent torsion on the left side. The common presentation is acute pelvic pain, sometimes with vomiting. You may got hemorrhage inside the fallopian tube. The torsed ovary is rotated and became midline above the uterus. It may be congested with blood signal, which may show high signal in the T1, and according to the stage of blood, it may appear like this, which is very dark, and the follicles are seen against the dark background. This is the normal left ovary. This is a female preoperative workup for breast cancer in the right upper quadrant. Carcinoma and lipoma, very good answer. This is fat and it is suppressed in the fat images, and this is carcinoma which is enhanced after contrast with fat suppressed images, and you have both lesions in the breast cancer and the lipoma. Next case is a female 44 years old presenting with urinary incontinence. And this is, of course, the T2 weighted images, and this is T1 weighted image, and this is axial T2. Yes, and this is mucinous cyst adenoma, ovarian mucinous cyst adenoma. The cyst is big, then this is number one. There are multiple internal septations, and this is number two. There are different signal intensities of the different loculi, and this is number three. There is absence of a solid mural nodule, and this is number four. Next case is a female patient, 64 years old, with abdominal and pelvic pain. Yes, a very good answer, leiomyoma. And inside the uterus, and you got a mass made of fat, and you know that one of the ways of degeneration in the fibroid uterus is fatty degeneration, and this is leiomyoma. Next case. Yes, hemorrhagic ovarian cyst, which is bright in the T1 and bright in the T2, and this is hemorrhagic follicle or hemorrhagic ovarian cyst. Next case. Adenomyosis, very good. And see, and if you got a lesion like this, and the differential diagnosis may include uterine fibroid, endometrial polyp, or endometrial cancer. But you know the major difference between uterine adenomyoma and fibroid is in the definition of the margin. The uterine fibroid is usually of a well-defined circumscribed margin, clearly separable from the adjacent myometrium. But the adenomyosis blends freely with the adjacent myometrium, and then you also may see some bright foci within the adenomyosis, but you may also see bright foci within the fibroid. Both lesions are of dark signal in the T2 weighted images and enhance after contrast injection. And you diagnose adenomyosis if you see that the junctional zone, which is represented by this black line, is of abnormal thickness. Then you measure the thickness of the junctional zone. If it exceeds 12 millimeter, you are sure about the diagnosis of adenomyosis. And many times you can see some cystic changes in the cervix, which represents Nabossian cysts. And this is the normal appearance of the uterus, and this is the adenomyosis. You got very much increased thickness of the junctional zone, and you got some bright foci within the lesion. And if you see that the thickness of the junctional zone is above 12 millimeter, and this is a good way for establishing the diagnosis of adenomyosis. The bright foci may be seen in the T2 weighted image in about 50% of the cases. They may represent heterotopic endometrium, cystic changes, or hemorrhagic foci. And sometimes you got bright foci in the T1 weighted images, and they may represent hemorrhage. Next case is a female patient, 35 years old. Yes, very good answer. This is uterine cervix carcinoma with retained secretions in the uterus, which are usually representing blood, because this is an adult female, and then the cervix is obstructed by the tumor, so the menstrual blood may be retained in the uterine cavity. And sometimes you got an endometrial mass which is invading the myometrium, and this is endometrial carcinoma. If the carcinoma has extended to the cervix, and this is a stage 2 endometrial cancer, but the cervical cancer is totally confined to the cervix, it may extend into the uterine body, and at that time you will see that the main bulk of the tumor is localized to the cervix. Next case is a female patient, 45 years old, with watery discharge, bare vagina, and lower abdominal discomfort. Yes, a very good answer. This is adenoma malignum, and it is of course different from the Naposian cyst because of the huge number of the cystic lesions, and also the offensive discharge through the vagina. These are two main criteria of the adenoma malignum in the cervix. Next case, a patient with gastric adenocarcinoma. Cartagnar syndrome in the chest, and I think you mean that this is a Krukenberg tumor. Krukenberg tumor, and these are metastatic deposits in the ovaries. This is the uterus with a contraceptive device, and this is the two ovarian masses with ascites. In the presence of gastric carcinoma, and you think that these are metastatic tumors to the ovary, which are known as Krukenberg tumors. Next case is a female patient, 40 years old, with menorrhagia and dysmenorrhea. T2, T1, and T1 post-contrast. Adenomyosis is the right answer, and you may see also some uterine fibroid, but the main bulk of the lesion is that one, and it contains, as I have said, bright foci in the T2 and also bright foci in the T1, and it will enhance with contrast material. Then the next case is a 15 years old female with enlarged pelvic mass, enlarging pelvic mass, imperforate hymen with hematometria and hematocolpus. This is the vagina, which is markedly distended by fluid, and in this age group you consider blood. Then this is hematocolpus. If you also can identify that the uterus is involved, but you cannot identify this in these images, and you say hematometrocolpus. Next case is a mammogram. This is the initial mammogram, and this is a follow-up study. Yes, this is breast cancer. Of course, it was missed in this study because of the dense architecture of the breast. But in the follow-up scans, in the follow-up study, it appeared very well identified. This is breast cancer. Next case is a female patient, 30 years old, with plain X-ray of this is a film obtained from an intravenous urogram. This is ovarian dermoid cyst because these radiopaque structures looks like the teeth, and this is one of the diagnostic criteria by which you can diagnose ovarian dermoid cyst from the plain film. Yes, and this is dermoid cyst. Next case, and you got this is CT, and this is T1 fat set, and this is T2 fat set of a big lesion in the pelvis. Yes, and this is highlighted. Of course, it's not hyperstimulation ovarian syndrome because you do not see the other ovary, but this is highlighted cyst because if you can look to the rest of the images of the CT and you see two other highlighted cysts in the liver. One of them is almost totally calcified, and the second one shows some marginal calcification, while that in the pelvis shows the classic appearance of highlighted cyst with a big lesion, and the daughter cysts are arranged on the periphery of the lesion. This is a echinococal or highlighted cyst. An hydatid cyst, as you know, is diagnosed by many features anywhere in the body. Number one, you detect a cyst with marginal calcification. Number two, and you see a cyst with floating shadows. Number three, you see a big lesion with daughter cysts arranged along the periphery of its inner margin. Next case is a female patient with abdominal pain. Yes, and this is right answer. This is liposarcoma. You see a big mass made of fat and some solid component in the right iliac fossa, and is not related to the uterus or the ovary. It is a retroperitoneal lesion, and it is a liposarcoma. Next case, and you see this is axial T2, and this is sagittal T2. Yes, cervical cancer, this is right. Big mass in the cervix with reticulation of the fat around the lesion. And if you look carefully here, and you may not see that the lesion has extended into the vagina. It is only totally confined to the cervix without any evidence of invasion of the urinary bladder or the rectum. And this is cervical cancer. Next case is a female patient. No, sorry, this is a female patient, 25 years old, with 4 days of worsening pelvic pain, purulent vaginal discharge. Yes, the answer is right. This is tubo-ovarian abscess on the left side, and you got marginally enhancing coiled lesions with some internal air loculi denoting infection, and this is a tubo-ovarian abscess. Next case, and this is MRI T1, and this is T2, and this is T1 post-contrast with fat saturation. Yes, this is the classic appearance of a dermoid cyst containing fat, which is bright in the T1, less bright in the T2, and is suppressed in the fat suppression images. Diagnostic of ovarian dermoid, you see some of the follicles in the left ovary, and this is the right ovary, which looks normal. Next case. Um, yes, the answer is right, and this is uterine rupture. You see here that there is a big defect in the anterior wall of the uterus with some fluids surrounding uterus from anterior and posterior. This is, of course, the urinary bladder containing some of the injected contrast material, because this is T1 post contrast with fat suppression, and this is T2 weighted images. Actually, you know that the scar of the previous section, previous cesarean section, is one of the major causes of weakness of the uterine wall, and the area of the previous section may become fibrous, and in the next pregnancy it may cause rupture of the uterus, as you can see here and in the previous case as well. This is one of the major drawbacks of the cesarean section. Also, another example, you may got that the pregnancy may be ectopic at the site of the cesarean section scar. And here you got T1 axial images of the pelvis, and this is T2, and this is T2 also. And you got two ovarian masses. I think you can see it clearly. There are two ovarian masses, and the differential diagnosis for ovarian masses are like this. Either you can see that it's bilateral ovarian cancer, or it is Krukenberg from a known primary malignancy, or pedunculated fibroids from the uterus, or bilateral ovarian endometrioma, or bilateral ovarian lymphoma. And you know, ovarian lymphoma is somewhat rare. Ovarian endometrioma may have a cystic appearance, clearly identified, not like this. And pedunculated ovarian fibroids from the uterus may be, and Krukenberg and bilateral ovarian cancer. Then this is an example of bilateral ovarian non-Hodgkin lymphoma. Two big masses in the region of the ovary, as well as enlarged, bulky, homogeneously enhanced lymph nodes. The previous case is not histologically diagnosed, but if you are confronted by a similar case in the exam, and you provide the differential diagnosis that I have said, including bilateral ovarian cancer, Krukenberg tumor, pedunculated fibroids from the uterus, bilateral ovarian endometrioma, and bilateral ovarian lymphoma. Then this is a hysterosalpingogram. This is the catheter, and this is the uterine cavity. Yes, and this is the right answer. A very big uterine fibroid, markedly stretching the uterus as well as the endometrial cavity. One of the important issues is you may think that this is an ovarian tumor, but you should realize that the ovarian tumor will not stretch the uterus along its border. It may displace the uterus or may elevate the uterus, but will not stretch the uterus along its margin. So if you see that the uterine margin is markedly stretched like this, you know that this lesion is of uterine origin, and the lesion which can give this appearance is just a fibroid uterus. Next case is a 50 years old female presented by abdominal distension with elevation, marked elevation of the tumor marker CM125. This is T2 and T1 post contrast with fat set, and this is diffusion weighted images. Yes, ovarian cancer with peritoneal metastasis, good answer. And you got two ovarian masses actually, and these ovarian masses are partly cystic and partly solid. Also on the right side, you got a cystic and solid component. This is definitely malignant. And these lesions are, as you know, that the serous cystadenoma is cystadenocarcinoma is more likely to be bilateral compared to the mucinous cystadenoma, and the incidence of serous cystadenoma is much more, or maybe 10 times common than the mucinous cystadenocarcinoma. Then the diffusion weighted image shows restricted diffusion of the solid component of the tumor, as well as restricted diffusion of the tumor seeding along the peritoneal reflection. And this is bilateral serous cystadenocarcinoma with peritoneal implants. Next case is a 60 years old female with abdominal distension. Yes, the diagnosis is omental cake. Then if you are asked about the differential diagnosis of an omental cake, and this is the differential diagnosis. Number one and the most common by far is metastatic tumors, especially the ovaries. Number two, the primary mesothelioma of the peritoneum. Number three, mesenteric lymphoma. Number four, TB peritonitis. Number five, which is an extremely rare condition, extramedullary hematopoiesis, and the myelofibrosis. Consider the first four possibilities, which can give this particular appearance: a sheet of soft tissue density in the greater omentum, and a lot of fluid in the peritoneal cavity. Next case is an MR mammogram of a female patient, 18 years old, with a 6-year history of multiple bilateral breast masses without any family history of breast disease. Yes, the answer is right. This is multiple fibroadenomas in the breast. Is a little bit strange that he can got one or two fibroadenomas in each breast, but here you got too many fibroadenomas in the breast, showing a homogeneous enhancement, well delineated outline. Thank you very much.